Hello and welcome to Inpatient Update. I'm your host, Mason Turner, and this is your podcast for practice-changing evidence for the working hospitalist. Today on the show, I'm joined by Dr. Ernest Murray as we bring out the evidence to test two antibiotic assumptions. Do hospitalized patients with community-acquired pneumonia really need 7 days or even 5 of antibiotics? And do we really need to tiptoe around the QTC every time we prescribe ciprofloxacin? Two common decisions, two prescribing reflexes, and two places where the evidence may push us towards a more precise approach. Let's get into it. Today on the show, I'm joined by Dr. Ernest Murray. He's a clinical hospitalist, mid-career hospitalist, and excellent clinician. Also happens to be one of the founding members and the inaugural president of our local SHM chapter, but not the current president. And is also just a joyful person to work with, and be friends with. So thank you so much for being on the show.
My pleasure. You're a joyful person to work around too, Dr. Turner.
Dr. Murray, is there anything else you think the audience needs to know about you?
Other than I'm really impressed with the setup here. So I'm going to come over here and crash in your little recording studio area here for my own personal gain at some point, I'm sure. This is cool.
So, Dr. Murray, how often do you treat a patient for pneumonia?
Like all the time. It's like our favorite. It's pneumonia and urinary tract infections. Hospitalists love diagnosing those two things. If not, we're going to find it,
Mm-hmm.
If anyone looks weird, we're doing chest x-rays. The chest x-rays, we overread them, we underread them. We sometimes just perfectly read them. But yeah, we love diagnosing CAP and CAP-HAP, all that stuff. CAP-HAP and BAP.
So for the community-acquired pneumonia, at least prior to this, did you have a hard and fast minimum duration you would give to patients? And we can get more into talking about this after we go through the article. But just what's your current practice pattern, or what has it been?
Yeah, I mean, for the last few years, basically since 2019, I think a lot of people have been going towards the 5-day plan.
Mm-hmm.
I think that the big study that kind of supported the 2019 thing was this Spanish study or I think it was initially, but mostly pushed by Levaquin. So I was always cautious about Levaquin being used as a primary agent because the half-life is so much longer. So I always write my note 5 to 7 days, but really 5 days. So most people kind of are okay with whatever agent being used for 5 days. And I've just slowly kind of been cool with 5 days. Mm-hmm. And now things are a little bit different over the last year, basically.
Yeah, certainly. Yeah, and I similarly, 5 to 7 days is what I have in my head. I'm usually, particularly if my patient's doing well, I'm happy with 5 days. And we had kind of previously was practicing giving people 5 days of the lower dose of azithromycin, but that atypical component, we'll do the higher dose, but just 3 days of that. But for the actual CAP coverage, we'll always do 5 to 7 days, at least until recently. So you wanna tell us about the article we have here today, and then we can get more into our thoughts and how this might change our practice?
Yeah, very interesting article that was published in the Annals of Internal Medicine that looked at using this target trial emulation, which is a very cool retrospective kind of study mm-hmm. that looked at community-acquired pneumonia in a group of people in Michigan. And so they looked in this large database in Michigan that's promoted by one of the local Blue Cross Blue Shields of Michigan and the Blue mm-hmm. Care Network, where they were able to squeeze out 60-something hospitals of information over a course of a few years between 2017 and 2024. And they were focusing on trying to figure out whether or not there was any difference between treating people for 5 days or treating people for 3 days for community-acquired pneumonia. And so they looked at this kind of retrospectively using this target trial emulation, mm-hmm. and the outcomes were 30-day all-cause mortality or 30-day readmission or urgent care visits, and then specifically the antibiotic-associated C. diff. And so they were able to squeeze out 55,000 cases in this retrospective analysis of CAP, but then they tailored the trial to look very similarly to this study, the PCT study that looked at a short course of pneumonia. So they had a very large exclusion criteria. So they were only able to get 5,000 patients, or roughly 5,620 patients, or about 10% of that big group of population to meet clinical criteria for the study. So they compared the control versus the intervention groups, where intervention groups were 3 to 4 days versus control was 5+ days. And they found that ultimately that there was no significant difference between mortality, urgent visits, C. diff infection, or readmissions. Some of the issues, of course, were that they could only find about 440 patients that actually met the criteria for the intervention. So, we're talking about out of the 5,000 patients, there's basically less than 10% of the patients, or 7.9% of the patients, were able to meet that criteria.
Actually had the primary outcome.
They actually had that primary. They were actually able to have antibiotics for 3 to 4 days during this time, and so that kind of adds a little bit of a limitation, if you will, to this. And there's a lot of interesting conversations to have about this retrospective approach. But that's what the study shows, is that 3 to 4 days may be safe. The issue, of course, with the confidence intervals being between 0.1 to 2.25, may be a huge range there, may be more of a factor. The fact that only 3 people died in the intervention side, and so that kind of perhaps blew up the kind of instability of the statistical analysis there, but kind of suggests something that we've seen in some earlier studies, which we can talk more about. But that's the result. The result is that maybe they're the same.
Yeah. I kind of see this is reassuring.
Right.
It's not necessarily groundbreaking. It's not necessarily major change. As I was saying before, I was so rudely interrupted. So the way I see this study is mostly that it's reassuring. Like it's not groundbreaking. It's not necessarily moving mountains, but it is a little bit of a comfort blanket that what I was kind of tending to start to want to do, and we can get more into the guidelines and why we're kind of tending to want to do that, and lowering my duration of my treatment for community-acquired pneumonia in people who are really stable. This has given me a little bit reassurance that at least the data doesn't show that it's worse, given the limitations of this study. What are your thoughts?
Yeah, no, I mean, I agree. Like, I think that they saw this need. There was this belief with the guidelines of 2025, and then previous studies, the PTC study that looked at using basically beta lactams to treat pneumonia for only 3 days versus a longer course, 5 to 7 days. That major study came out, and then but it was only powered to 140 patients. So they were like, let's do this bigger thing retrospectively, because that PTC study basically was the actual clinical trial that they emulated this one from. And so they were like looking for ways to support this idea, to build the literature to move towards more of a 3-day thing. And I think that they did a good job. They did a fair job. I mean, it's cool how they can just look back on this whole body of data, between 2017 and 2024. Of course, the big issue, of course, is that something happened during that time.
Yeah, what was
they
Tell me again.
They excluded COVID.
Yeah.
They excluded a million things, obviously, but they excluded COVID.
Right. Which that was, and you kind of alluded to this, or you specifically mentioned it, but obviously a big limitation and a big caveat of this, as far as generalizability of the headline here of 3 days of antibiotics was just as good as longer, is, like you said, only like 10% of the patients met the inclusion criteria. Of everyone with pneumonia in this system, only 10% didn't get excluded, and like a couple of the things they excluded for that were, underlying severe lung disease, immunosuppression, like pretty obvious stuff.
The stuff that's
But then anyone who you thought might have a drug resistant organism, or I guess whether they did or if they were being treated to it. So anyone who was on, Vanc, cefepime, or presumably Zosyn, because they said anyone who had pseudomodal coverage for 2 days got kicked. And so it's going to cut your numbers down a lot if you're treating hospitalized patients with pneumonia.
Do they have to be that stringent on it? Look. I looked at it closely, and I think the funniest thing was that they mimicked that study, the French study, the PTC study, so much that they actually said that if you're allergic to beta-lactams, you got excluded from this too. Like, they didn't have to do that.
Right.
Because looking at this, these patients received all different types of antibiotics. They didn't just receive Cipro, like they received all the antibiotics. So they didn't have to do that. It was like, they emulated it so much that they could have included those patients that didn't have allergies,
Right.
It's like, why did they do that?
Yeah, I think I agree with you.
That was kind of interesting, but, I think they were trying to be honest with the way how they did it. They tried to mimic it. That's kind of a testament of how much they were trying to make it look like a clinical trial,
Yeah. Yeah, certainly. Yeah, these target trial emulations seem to be pretty in vogue right now, of just like, how can we be as rigorous as possible in our essentially a retrospective study, what is entirely a retrospective study, but what we would have used to have done just a retrospective cohort. Now we're trying to be a little bit more rigorous, and they threw out some patients that maybe they didn't need to.
Yeah, I think the interesting thing is that, we're trying to support, these guys were trying to support the idea that using antibiotics less is better. In 2019, these exact same guys came out with a study that showed that using antibiotics longer increased antibiotic-associated side effects by 5% for every day that you do it. So these guys were gung-ho about doing that,
right?
For good cause too. These are the crown jewels of medicine, and we are afraid to hurt people, But they supported that with this, and I think that with the 2025 guidelines, I think it's opening the door for us to use antibiotics less. Looking closely at those guidelines, in 3 days, can you really eradicate an infection in 3 days? And I think the answer is you're not, actually. You're not eradicating the infection, but do you need to?
Right. Totally. I like your point. There's, in all of antibiotic treatment, there's so much of a less is more push.
Yeah.
And so much of, you're fine.
Yeah.
There's so much of decreasing duration being a priority, and usually the data backs it up, that we get, at worst, the data we have here, that's at least that it's not worse.
Yeah.
But a lot of times, we're getting that pretty consistently. And sometimes we're doing randomized controlled trials, sometimes we're doing these sorts of retrospective trials, but we're seeing that more and more, and that is the push. But obviously it's within the caveat of, you look at your whole patient and you're treating your whole patient. You're not, and I think that's what this does for us, is I think before, like you say, we don't want to hurt patients. We kind of do a more is more and reflexively say, all right, everyone gets at least 5 days, or some people everyone gets 7 days. But this is giving us sort of the comfort to be, okay, let's just take this patient by patient.
Yeah.
Let's look at the patient. Let's not look at the diagnosis code and just say that's going to determine what their treatment is. A equals B, we're going to look at the patient in more context of them, and maybe we're going to get rid of 90% of our patients. We are going to do 5 to 7 days. But 10% of our patients, if they look good, then maybe we stop.
Yeah, it begs the question, in 2017 when they started collecting this data, who was actually doing 3 days for CAP treatment, right? Like that was like
I wasn't.
What clinician was doing that, and why were they doing that, right? So like how could you?
That's why there are so few.
Right, yeah. Why were they doing that? And you can't like adjust for a clinician decision making like for that particular thing. So obviously these patients were probably a little bit more stable than your conventional patient. Or they had some other confounding thing that made you think that antibiotics wasn't too big of a deal, though they still met criteria for treatment, because that was also looked at. And so when I look at that, I'm like, well, maybe these are the wrong patients. These are not my patients, And the way how I get kind of allayed to that concern is that the 2025 guidelines support it, but also the first thing when you reached out to me talking about something like this, I was like, well, actually, there's data in the ICU for that we can also treat for 3 days. So like I look at something like a change in my day-to-day management as being something that exists on more than one side, like how many blind people touching the elephant to make the right decision. And so the critical care doctors are looking at that and saying, with the Regard VAP trial, that you can get away with doing 3 to 5 days in somebody who is, hemodynamically stable, they're doing okay, they're not, they're not requiring pressors.
But sure as all get out being excluded from this trial.
They would have been excluded because they were in the ICU and they were intubated, for 2 days, So like those patients sometimes are doing okay from with the only 3 to 5 days of antibiotics. So if I'm seeing it from these higher risk patients, then maybe we don't need to eradicate it. Maybe we don't have to push that hard to treat patients with antibiotics. And then looking at the ATS 2025 guidelines, they comment on the lung microbiome as well, which I didn't know that much about. Yeah, everyone talks about the gut microbiome, but if you look closely, the lung has other stuff in it as well. And knocking out everything may not be as
that's fascinating. I missed that.
Yeah, there was a paper there, and I was looking. I was like, oh my gosh, I never thought of it that way.
See, in my head, I'm like, and this is how I've done with patients. I'm like, I want my lungs to be sterile,
completely sterile. Well, I mean, if we're doing, but if you do a bronch and whatnot, you're gonna find, that they're gonna be like usual flora or whatever.
Oh, yeah.
We only point out the stuff that's bad.
Yeah, exactly. And where does that? We're doing all these sputum cultures. And, it's almost a joke always because they almost never give us a productive organism when we're just doing a sputum culture. But where does it stop that it's okay to just have bacteria? Is it, the mouth? Yeah. Where does it stop? And what I'm hearing is, there's
probably some
natural microbiome.
And then knocking everything out may not be knocking everything out completely sterile. You lose a little bit of your body's ability to handle what's going on.
Every other surface of my body that has any communication with the outside world has bacteria on it, like my skin, and this air that we're breathing is in my lungs too. Yeah. So how could I not? We just honestly don't think about it. And I like the thought of thinking about antibiotics as almost like we don't need to think about sterilizing things. We're just sort of trying to kickstart the destruction of the pathogenic organism that then your body's going to take it from there. That the course of doesn't have to be, all right, what was it going to take to totally eradicate this organism? Yeah. It's what's going to take to control this organism to the point that I'm no longer actively sick, and then my body's immune system does the rest.
You won't need it to be treated again. You don't need to have readmission for that. And I think that's kind of an interesting way, like the whole idea behind the asteroid coming towards Earth. You don't need to blow up the asteroid. You just need to push it a little bit out of the way. You don't have to. You just got to move. Just bring out the small.
And the outcome's the same. Yeah. The 30-day mortality of the planet.
Yeah, that's right.
Whether you blow up the asteroid or skid it away.
Can swing by just fine. You don't have to blow it up. Just make sure it doesn't hit us. That's one of the cool things that I picked up just looking into this a little bit more. My doubts about guidelines are they're a little bit, everything during my training, because I got out of residency in 2014, and between 2011 and 2014 was a big change. Mm-hmm. We looked at the 2007 guidelines and said that we were going to treat severe pneumonia with activated protein C. I don't know if you remember what that was. But, I remember when I was a medical student, I would look at these cool pictures of slow-moving blood moving through capillaries saying that BIC and sepsis, acute sepsis from community-acquired pneumonia, was this crazy thing that was a procoagulable state. And we would give Xigris to treat this type of, procoagulable state. And then what ended up happening is that in my first year of residency, they pulled Xigris from the market because it was causing bleeding issues.
Yeah, wow.
And that stayed on the guidelines for between 2011 all the way to 2019, So those updated it's a document that we can see that there are going to be things that we recommend, and those things have to be kind of met with a little bit of reservation. Yeah. And so things change. And so when I see something like we're changing the antibiotic timeline, or we're doing something big that changes every day, the way how we treat medicine, I like to have more than one piece of information. Yeah. And that's why I was like, okay, look at the critical care guys. What are they doing? So I think this is a cool kind of a cool idea that they're using a kind of an interesting way to look at it from a different angle too, but highlights kind of what I think is probably more of a cultural shift.
And we should say, it's talking about the guidelines. We've talked some off the air about this, and then we've referred to them some. But specifically, they're what have at times been the ATS, IDSA joint guidelines or just ATS guidelines on pneumonia. The 2019 guidelines said a minimum of 5-day duration for treatment of pneumonia, carte blanche. But then these updated 2025 guidelines, for anyone who hasn't seen that yet, had said that, so basically the minimum is 3 days, and the recommendation less than 5 days if they're really stable. Basically, what we're seeing in this study, and despite some of the trauma about those guidelines, the IDSA backed up and agreed on that part. So
mostly
IDSA
agreed. Mostly agreed.
But any other specific thoughts on those guidelines you think that people need to know?
This is a good question about what are the kind of patients that we're talking about here, other than requiring hemodynamic stability, other than requiring that you're afebrile, other than you're off of the oxygen. The other thing is like what's the patient population? And our patient population are the multi-organ system failure, solid lung and transplant, or solid organ transplant, people that are on steroids. Those are the patients that were all excluded, So like people that are immune suppressed, they probably bought themselves a few more days of antibiotics, even if they are clinically improving fast. But a majority, the question should be asked for those relatively stable patients who are not in that kind of higher risk category.
Yeah. Agreed. Yeah. Sort of my takeaway, taking the 2025 guidelines and, like you're saying, the data on VAP and this data, basically my takeaway is that my mental minimum needs to be 3 days, not 5 to 7 days. But I'm treating my patient in front of me, and they have to be very stable, not complex,
right?
For me to be comfortable doing that minimum, at least based on current evidence.
That's my take on this as well.
All right, great. Well, thank you. Well, let's move on. I will say, in addition to being an expert clinician, Dr. Murray is also an expert guitar player, and he's actually spent a decent amount of time in this exact space with me. He alluded to that a little bit. Yeah. It's made some recent changes, but he's come over here several times and brought an instrument, and we've jammed. The instruments are real. Someone asked me that recently.
Oh, really?
Whether this was a background, but
this is.
It wouldn't necessarily be my chosen background, but this is the extent of the space that I have.
Is a front for the instruments. This is instruments were here first.
Yeah, exactly. We've gotten together. We've jammed a few times. I remember really excellent guitarist. He
I play bass as well.
I feel like So, my gosh, and I wonder if my buddy Tim Wood listens to this podcast at all, because he and I get together. We'll jam occasionally. Ernest Murray here heard about that and was like, I want to get involved. And we were like, I don't know. Do we need another guitarist? We're just two people playing instruments. Maybe don't need another guitarist. And it's really low key. And like, we don't want to intimidate Tim trying to play his guitar. And Ernest is like, no, I'll play bass. I wanted to learn bass anyways. I'll play bass. So he brings his bass, and his bass amp stands right there in this room, and we jam. And I'm playing some drums, playing some keys. Ernest is playing the guitar, and at some point,
the bass guitar.
Ernest is playing the bass. Tim's playing the guitar, and at some point, Tim is like, well, Ernest, you play guitar. Like, let's mix it up. You try. And Have you read Harry Potter?
My wife has read it plenty of times.
I'm sure she has. But like in Harry Potter, if you're in a wizarding duel and you disarm your opponent, then their wand will then have allegiance to you instead of the wizard that you've disarmed. That's about what happened. to my buddy's guitar when Ernest Murray picked it up and just wailed on it.
It was a good guitar, too.
Just an epic guitar.
I don't play a lot of electric, but that was a nice electric instrument. I think it was I don't even know what it was. Like a Dubin something another.
Dusseldorf, whatever it was.
And I was like, I don't know a lot about electric. That was a cool instrument. It was
that
like
instrument is always going to have allegiance to you.
Yeah,
after
it was a
what you
Gretsch
did
wannabe. Kind of want to buy one of those now, but no.
No, I joke. And to be fair, Tim is an excellent
he's
guitarist.
fantastic.
Oh yeah, and very very skilled, very musical.
Also,
I'll just have like slightly different skill sets. Your notes per minute, you can get up there with your.
I
notes.
have a problem. Yeah,
notes per second, really.
I have a problem with playing too many notes.
I mean, you've gotten into bluegrass.
I've started recently playing bluegrass. Yeah, it's been a lot of fun. But we actually ended up switching all the instruments too.
Oh yeah. I'm standing there playing a bass, like I know any idea what I'm doing.
But then I played piano as well. I was like, let's keep it in the key.
I'll tell you,
keep it in the key.
I'm not a great keyboardist, but you did not.
I do not know how to
You did not disarm me from my wand with your keyboard
playing. Please play only the keys that are in this key of C, because then I can just mash my hand on the thing. That was fun. But yeah, we have a lot of fun playing, and also we have a lot of other musicians in our group. I think music is a common theme.
Yeah,
in our group.
Well, getting back to medicine, I think one of the sort of takeaways from the previous trial we talked about is like if you are allowing yourself, if I'm treating someone with community-acquired pneumonia who's admitted 3 days of treatment, if they're stable, then one of the big benefits is you're saying, okay, now I don't have to put them on oral antibiotics when they discharge. Because usually if they're stable, and they're capped, it's been 3 days, like you're getting this person out of the hospital. And so speaking of oral antibiotics, not exactly in the lane of treating pneumonia, but in trying to transition to someone with oral antibiotics, which is something that we do in the hospital often, we're going to jump into another study. And so, Dr. Murray, how often do you prescribe fluoroquinolones?
Oh man, I want to say I prescribe it often, but I can't really because our institution has a restriction on them. So it's not as common. It's not as common as I'd like. And when I do
so how often do you want to do it, but you can't for some reason?
Oh yeah, I mean, look, a lot. I think I get to
daily.
I probably prescribe it. I probably actually prescribe it a couple of times a month because of gram-negative bacteremia, and I think that's probably the most common thing. Is that now we are avoiding. When I say now, it's not recent, but we stopped doing IV antibiotics for uncomplicated gram-negative bacteremia, and we do kind of these. Fluoroquinolone is a fantastic agent to use because it has excellent treatment for bacteremia.
Oh yeah, it's sitting there crossing our fingers, hoping the gram-negative rods end up being something that's susceptible to Cipro.
And super rarely, but occasionally, the bigger dosing for Pseudomonas, if you can get a Pseudomonas, is susceptible to fluoroquinolones. Yeah, and it's not common, but it'll happen every once in a while.
Yeah, I mean, great med for us. If we can use it in that you got an oral medicine you can treat Pseudomonas with, that's fantastic and incredibly liberating. And also an oral medicine you can treat bacteremia with. Often we've got like UTIs that are resistant to a lot of stuff except for Cipro. So it's a medicine that like we want to use a lot, but either our institution prohibits it or limits it, or we're worried about complications. Because it's certainly a medicine that, it's got a black box warning on it.
It's a pendulum though, right? We used to prescribe it all the time. I used to work at a facility, which I won't talk about, but when my first days on the job, and it was one of these kind of like facilities where you take care of patients kind of remotely, where it just seemed like every person who had a urinary tract infection or anything at all was getting fluoroquinolone, and it was prescribed quite heavily. So I think our current culture is a pendulum against prescribing it and maybe swinging back a little bit.
Yeah, certainly. It's a powerful and useful med. So there was this recent study, and part of that pendulum swing. It's a really interesting little study. It was in the Journal of Antimicrobial Chemotherapy just recently. That was called The Effect of Oral Ciprofloxacin at Conventional Doses on the QT Interval in a Tertiary Outpatient Setting, which that kind of tells it all. I mean, it is what it sounds like it is, that it was a retrospective study where it was patients that they had, they were like us, they were wanting to prescribe Cipro for people, and they were. And they're particularly looking at that QTC prolonging concern when it comes to Cipro, and trying to see, is it valid? So it was a relatively small study. This was 88 total patients. And at this like single tertiary referral center. But what they specifically did was they did an EKG on before they started therapy. Mm-hmm. They started Cipro, standard doses. There was a variety of doses, but everything within what you'd typically be putting a patient on. And then 2 days after starting therapy, they did an EKG again. And then they did some statistical analysis to compare, was there a statistically significant difference in the QTC before Cipro and after Cipro? And they picked the 2 days because for the half-life of Cipro, that should be steady state.
Sure.
And this was their, and part of the reason, I mean, it was easy for them to do this study, as they say in the study, this was their standard of care whenever they started patients on Cipro. Whenever they started, Cipro specifically, fluoroquinolones in general, I presume, they would get a 2 days later EKG, which the setting of this clinic, which I think was like a wound care clinic and stuff, people came in often, I guess, and there was a home health component, so they had the benefit of being able to follow those patients that much. But so they specifically looked at this, and so the headline takeaway was QTC was not statistically significantly different before or after Cipro when they did sort of the average QTC for both groups. 415 on the button both times. Some people would go up, some people would go down, but really, I mean, it's a relatively small sample size, but I mean, it literally, like they had a little graph where you could see everyone's QTCs between the two, and it looked like random. It
looked insane, yeah.
It's like some of them are a lot more, just like they would, like anyone who gets a lot of EKGs and looks at QTCs, which is most of us hospitalists, like they're up, they're down, they're all around, like they change.
But the average across the board
was, it didn't seem, we didn't have any indication based on this data that the Cipro itself was really making an impact on that. 2 patients did end up, so I think only one patient, they said they didn't start the Cipro for specifically within the people they were considering because their QTC was greater than 500. And then 2 patients were greater than 500 afterwards. Which is an important caveat, but again, in the setting of all of this, and randomly people going up and down, could certainly just be noise that they just happened to be on that day a little bit higher. And they do specifically say they looked into, was there anything sort of out of the ordinary with these people, and I think they had mentioned some, like one of them had some diarrhea and that kind of thing, and then the other one, concurrent amiodarone and metoprolol. And so, and one of them was on DELT. So they had like other reasons that they might have changes in their cardioelectric activity and their QTC specifically, which sort of backs up that don't really see a statistically significant difference in the QTC when you start Cipro on these people.
Yeah, I mean,
what are your thoughts?
I think that like I love the talking about Cipro, because it reopens the conversation about bringing this back on board more regularly. You talked about the black box warning. I had to look up the black box warning again. It was actually multiple black box warning for Cipro, and it's not just myasthenia. It's not just concern for prolonged QTC, but it's also like the tendonitis rupture. Everyone knows about that. Peripheral neuropathy, central nervous affection. Then of course, there's this concern for dissection as well. And so, looking at how dangerous it is in terms of QTC, is that really another concern? And should we be worried about it? And, I think our patients are going to have our patients are going to be on all the medications that you have to worry about while you're on. They're all going to have hypokalemia. They're all going to have these other things that are going to be increasing risk. But in general, should you be worried about, with a relatively stable patient, whether or not Cipro is going to be playing a role? I think that I think the answer is probably going to be a little bit less concerning for anybody. Going back to why people are so focused about QTC in these patients is the fact that, before I was a hospitalist, many years ago. I used to be a chemist. I used to make
That's
medications.
right. That's right. Yes.
That's why I personally am intrigued with this kind of stuff because, when I started off in chemistry back in the early 2000s, the FDA was pulling medications off the market because it was hitting a receptor. It was hitting the potassium rectifier channel. It was hitting something called the human ether-a-go-go gene receptor, right? The HERG receptor.
Okay.
It was hitting things. It was like they were pulling medications off the market. They were pulling off like medications for your sign, like the Celdane, which is an antihistamine, was being pulled off the market. But the active metabolite was fexofenadine and ended up becoming Allegra. So I was, when I was making these molecules, in 2002, everybody had to have medications that proved it wasn't hitting this receptor, because this receptor was getting hit by everything. So basically, I don't know what the percentage, but a large percentage of medications out there in the market right now, at a high enough dose, will act as a class 3 anarrhythmic. They will hit this. And so when we think about this, it's like, I think that they courageously looked at this patient population with doses as high as 1,500 milligrams, 750. That's the big dose.
Yep.
So they were really pushing hard, and they were saying, hey, we really only see this issue when it gets to 100 micromolars in the 100 micromole concentration, when normal concentration is 10 times less than that in the blood. And that kind of highlighted the fact that maybe we only have to worry about the people who are really kind of have these higher concentrations of, people with end-stage renal disease, or whether or not they have acute kidney injury, or they have these other things that are kind of increasing the cardiac irritability, And so a patient who is completely stable, not having anything, should you be worried about getting an EKG? And the answer is probably not.
What's your practice for Cipro now? Do you make sure you have a baseline EKG? Do you tell them to follow up with their PCP to get an EKG if you've started someone on it? Do you get one if you're starting in the hospital? We give a lot of it in the hematologic malignancy standpoint, not that 750 dose, lower dose, but we're giving it. But usually in that case, we're not the ones starting it. We're continuing it. But we've got a lot of patients who are on the Cipro. Are you
for neutropenic?
Are you exactly
prophylaxis,
neutropenic prophylaxis? Are you routinely getting EKGs in one interval?
I think these guys are getting EKGs basically every other day for whatever reason.
Yeah,
and patients that are these patients that are kind of prophylaxis for like prolonged neutropenia and whatnot. They're on so many medications that you have to kind of look at, because they'll be on like voriconazole, or they'll be on tons of other medications.
If you've got a E. coli bacteremia though, or something, and it's susceptible to Cipro, and you're trying to discharge the patient on oral, what do you do with EKGs? Anything?
I mean, if the person who's getting E. coli bacteremia is probably not the 100% completely normal person. It's not this person who's getting outpatient treatment for bronchitis or something like that. These are the patients that probably have something else going on. They're on medications that can interfere. So you probably are. And so is that going to change what I'm doing right here? If they are nothing, then I think I feel a little more, but if you have to kind of look at their meds.
I'm getting a baseline EKG at least, because as a hospitalist, it's like, well, why not? It is someone has to do the work to put these leads on them. But if they've got a reassuring initial QTC, then I'm not worried about like, hey, once I start this Cipro, you need to follow up in 2 days and get an EKG from your PCP or anything like that. And this reassures from that. So I think it's helpful.
I think a lot of us too will get that 1 or 2 dose, that we don't wait for the steady state too. So are we even doing a good enough job? Are we doing the correct job in figuring out whether or not it's truly going to have effect after it reaches steady state? And I think that we're doing these half measures probably a little more than we'd like to admit, but I think it's okay.
Yeah, I think it's. I agree. I think, and I think that kind of goes to your point for concern about QT in general and QT prolongation, because obviously that's just the number, and we don't actually care about a random number we calculate on the EKG. We care about the complication.
That's the point. Yeah, and I've tried to mention earlier that the one person that I saw was in the ICU receiving IV, I think it was IV phenytoin. So it was like an anti-seizure medication that sometimes is associated with it. Then if you receive an IV medication, that increases the likelihood of it happening. They were in the ICU receiving IV phenytoin. They had a low mag, and they were also on amiodarone. So they were they had several things, and what we do is always for someone who has an unstable polymorphic VT is that you give mags, just no you shock them first, right? Because you're in the ICU and this guy's crashing. And so that was I think when I saw that in my training many years ago, I was like, that helped me kind of realize that, this kind of whatever it says, 0.3 per 10 million cases per 10 million prescriptions.
For Cipro.
Yeah, for Cipro alone. Is that really, that really means it's never happening? No, I mean, it happens. It's not documented as much as literature, but it happens in my short career. I've seen it happen. And so it's something that we pay attention to. The FDA was right to start paying attention to it as well. We're going to make 10,000 decisions a day. I think you have to kind of, make sure that you protect yourself from that idea.
I think it's the kind of thing that when you like start prescribing medicines as an intern, you're a little bit probably over hyper aware, because you're like the intern page of an antiemetic, you're constantly getting that, and you're like, okay, they need an EKG, and then, but to your point, the patients that we're actually seeing either significant prolongation or, a lot more importantly, actual bad outcomes from this it's the people who are on, it's multifactorial almost always. And it's going to be significant. It's not a patient who's on no other medicines. Electrolytes are okay, and you're giving some ondansetron. Like that, you're not doing it. By generally, that's going to be really unlikely. So I think generally, thinking about QTC as a whole, to your point, it's something to keep in mind. It's something to keep in mind that can cause a problem. Keep the mental list of the medicines that can contribute to it, and be aware when you're giving several of those at once that you need to dial back or need to be cautious about it. But we don't need to necessarily deprive someone of a medicine like Cipro that can get someone out of the hospital sooner because it gives them an oral option, or alleviate them of an IV, or a PICC line when they go home, or something like that.
Yeah, I think everyone's going to pick Cipro, and even if it's people could look at that QTC and see that's not going to be the barrier.
Right.
I think this is basically going to be help you guys allay your concern a little bit about initiating for a patient who probably you probably have other options. So
right.
So I don't think that this is going to be incredibly practice changing, but maybe kind of bring down your concern just a little bit.
Yeah.
Because what is something that is a study that only has 88 patients powered enough to look at an event that happens 0.3 per 10 million. Yeah, it's a good question.
All right. Any other thoughts on this trial?
It's cool, man.
All right. All right. So I'll give my major takeaways from our trials today are: for a patient that is stable and improved after 3 days of treatment with antibiotics for community-acquired pneumonia, I don't need to reflexively do 5 to 7 days. If I think the patient's better, I can stop after 3 days if it looks like they're stable otherwise, and the evidence we have supports that they won't do worse in the aggregate. And then when I'm prescribing Cipro, there are the other limitations, but when it comes to QTC, the evidence supports that there's not a massive change in the QT. And so for my practice going forward, probably getting that initial QTC with an EKG, checking their med list, and as long as that looks good, being comfortable starting a patient on Cipro and not worrying too much about following up QTCs going forward. And maybe use Cipro a little bit more to switch people to oral options.
If our institution will allow it.
Yeah, exactly. Well, certainly outpatient.
Outpatient,
I'm not having a problem. Yeah, inpatient. That is one thing, is that I'd love inpatient to be able to be de-escalating people off of IV, IV anti-pseudomonal sometimes, or whatever, or IV meds for the bacteremia that's susceptible to a fluoroquinolone, and our institution does limit that.
I think for bacteremia it's going to be, and we're doing it a lot more, but I think that's the big.
Yeah, that's exciting.
Advantage. Very cool.
All right. Any other thoughts? Any other takeaways? Anything else for the audience?
Thank you for letting me join your little rundown here. It's been fun.
Yeah. Thank you so much. It's been an honor and a pleasure, and I appreciate your time and your insight. And I think everyone who listens realizes that Dr. Murray is like a walking textbook and has a lot of insight. And so I'm really grateful, but I think the listeners will be grateful too.
We'll delete that from the master copy.
And for my listeners, if there's any new evidence you think hospitalists should be talking about, Or if you're a clinician with insight that could help us take better care of hospitalized patients, reach out. Find Inpatient Update on social media or email me at podcast@inpatientupdate.com. And if you found this useful, please share it with your colleagues, trainees, or anyone involved in inpatient care. Thank you so much for listening. This has been Inpatient Update.